You're listening to Conferences Online Allergy from Children's Mercy Hospital in Kansas City, Missouri. Today is July 22nd, 2024. We are doing our orientation series, and our topic today is Allergen Immunotherapy. This is presented by Dr. J. Portnoy, a professor of pediatrics, and Dr. Arti Pandya, an assistant professor of pediatrics in the Division of Allergy, Immunology, Pulmonary, and Sleep Medicine at Children's Mercy Hospital.
Welcome back, everybody. It's 11 o'clock. We're going to start with our second presentation today on Conferences Online and Allergy. Dr. Arti Pandya will be speaking about allergen immunotherapy. Thanks, Arti.
Thank you, Dr. Miller. We'll go ahead and get started here. So our talk is going to be on allergen immunotherapy. I'll be our primary presenter today. My name's Arti Pandya. I'm an assistant professor in pediatrics. Dr. J. Portnoy will contribute anything he has to add to the presentation. He's a professor of pediatrics also here at Children's Mercy. So in terms of disclosures, I did want to say that I am a writer for our practice parameter immunotherapy revision relevant for today. Our learning objectives include selecting appropriate candidates for allergen immunotherapy, modalities of allergen immunotherapy, including subcutaneous and sublingual, developing an extract for treatment for the patient's history, as well as matching their sensitization pattern, and then safety precautions with subcutaneous immunotherapy. There are different scenarios that may come up when you're seeing patients, and all of those scenarios we have to kind of evaluate to see who is the best candidate for immunotherapy. Here are some such scenarios. A 12-year-old with nasal symptoms lasting 2 weeks during oak pollen season, a 4-year-old with nasal symptoms that occur episodically, 7 to 10 days that are more frequent in the fall, no symptoms in between episodes, a 14-year-old with chronic urticaria and dermatographia who has numerous positive skin tests for aeroallergens, but only minimal nasal symptoms. So things we take into consideration here is, the pattern of symptoms here. For instance, in this particular individual, symptoms that are lasting for 2 weeks during the oak pollen season. For the second scenario, symptoms that are occurring in certain seasons, but they're asymptomatic between the episodes. And then the third scenario here, there is a strong history of sensitization on testing, but minimal actual symptoms in terms of rhinitis and conjunctivitis that was taken on history. Another scenario here, a 2-year-old with asthma, and their specific triggers for their asthma include colds, potentially dust mite, and then mold. A 13-year-old with severe nasal and lung symptoms when exposed to cats. They love animals and they want to be a veterinarian. And then lastly, a 16-year-old with perennial nasal allergies, or nasal symptoms, we should say, and asthma that are worse from early spring through fall. So taking the age into consideration, taking the clinical scenario here where they have symptoms when exposed to the trigger, and then of course future plans as well. And then lastly, potential seasonal pattern, which we see here in the last situation. However, their testing is kind of discordant because their sensitization pattern is more perennial. So current modalities that are available for immunotherapy include ones that are standardized or FDA approved, and then ones that are beyond the scope of this talk. Currently, ones that have some standardization component as well as non-standardization component but are FDA approved include subcutaneous immunotherapy. This is also abbreviated as SCIT, and then FDA approved sublingual immunotherapy tablets. This is largely going to be SLIT. Other modalities that are utilized but are beyond the scope of this discussion include sublingual drops as well as intralymphatic immunotherapy. Both of these modalities are used for immunotherapy in the United States. However, they're not FDA approved, and so they are kind of beyond the scope of this talk as we're talking about those specific modalities. So talking about conditions that are going to improve with allergen immunotherapy, or conditions where you meet indication essentially for doing allergen immunotherapy, include one or many of the following, and then we'll talk about ones that don't here at the end. So nasal dysfunction syndrome, also allergic rhinitis, allergic rhinosinusitis, if there's sinus-related symptoms as well. A colloquial term we use is hay fever, which is essentially referring to the same thing. If you have ocular allergy, this is called allergic conjunctivitis. If you have asthma that is specifically allergen-induced, this is going to be allergen-induced asthma. Atopic dermatitis, hymenoptera, and fire ant hypersensitivity. This is only with the modality of SCIT, so not referring to SLIT right here. And then for food allergies specifically, so this is not going to be with general all IgE-mediated food allergies. Could there be a role with oral allergy syndrome? Potentially here, although this is not a strong indication and certainly not an indication alone to initiate allergen immunotherapy. And then some of these other disorders here, while this has been questioned whether there's a role of allergen immunotherapy, there's not currently any indication to do so, including mosquito allergy or any autoimmunity or autoimmune disorders. When we're going through this particular topic, one thing to take into consideration is the immunologic changes that occur with allergen immunotherapy. So there are many such changes that occur for us to think about. There are changes that occur kind of on like an epithelial level surface or epithelial surface level. There are changes that occur to our humoral immunity, our cell-mediated immunity. So all of those things have to be taken into consideration. Here we can see that allergen-specific IgE will initially increase while you're on allergen immunotherapy and then subsequently decrease over time. We know that allergen-specific IgG4 levels increase, especially later on during the immunotherapy, and then we have allergen-specific IgA levels that rise in the serum as well as secretions. We are going to have an increase in allergen-specific T regulatory cells, as well as the interleukins that are linked with that, and then a shift from Th2 cytokines to Th1 and T regulatory cytokines. In general, there is going to be a suppression of Th2 and ILC2 response, and then suppression of effector cells such as mast cells and eosinophils. So who qualifies for, specifically here, we're talking about subcutaneous immunotherapy. So who qualifies for that? What are the criteria? So it has to be a condition that's indicated for the actual immunotherapy. So the ones that we talked about here on a previous slide include nasal dysfunction, asthma, possible atopic dermatitis. I do want to preface here that this talk, while it's labeled allergen immunotherapy, largely we're going to center around aeroallergen immunotherapy. There are separate talks that are going to be reserved for venom hypersensitivity and subsequent venom immunotherapy. Secondly, you have a condition where relevant allergens are actually triggering your condition. So you can perform a skin prick test or a specific IgE test, and are those correlating with the clinical scenario that your patient has come in with? Or is there a scenario where they're just having colds all the time and their allergen pattern is not really matching that? So that would be a discordant history with testing that you're observing. And so you have to kind of think, is this really relevant for this patient? Is this patient really going to benefit? Because allergen immunotherapy is certainly not a zero risk therapy, and it certainly has a lot of logistical things that need to be done on patients' end. So all of those things have to be taken into consideration. And then I think a question here that was previously outlined, can we use specific IgE testing to prescribe allergen immunotherapy? The reason this comes up is because in the previous practice parameter, largely only skin prick testing is used to, is brought up in the recommendations with regards to allergen immunotherapy. However, we know that subsequent data has come out that has demonstrated utilization of allergen-specific IgE testing with regards to preparing immunotherapy, whether that be subcutaneous immunotherapy scripts or consideration of sublingual allergen immunotherapy. So there could be two modalities of testing that you use to take into consideration when you are thinking about allergen immunotherapy. Then your symptoms are refractory to these two things here. avoidance measures and medical therapy as well. So both of those things have kind of been attempted to the best of the patient's ability, and despite that, they are still not achieving optimal symptom control. They are not where they want to be in terms of their symptoms. And then lastly, a big one which we want to think about is the patient's desires. If they have a strong desire to do allergen immunotherapy, understanding the risks, understanding the expenses, understanding how much that they're going to have to be coming in the clinic, let's say for subcutaneous or, for sublingual, the importance of compliance with daily therapy, then that's another thing to take into consideration. So all of these things are things we want to kind of think about and kind of use in terms of our decision making with regards to allergen immunotherapy. Where should we exercise some precaution with, particularly with subcutaneous immunotherapy? And again, this is kind of based on our literature with regards to allergen immunotherapy. You may see things outside of this talk here in other clinical practices that are different from what I'm presenting here. So just kind of take that into consideration. But here, medical conditions that increase a risk of either systemic reaction at baseline or difficulty with treatment of a systemic reaction. So this includes uncontrolled asthma, if you have coronary particularly if you have uncontrolled cardiac disease or uncontrolled any other pulmonary disease as well. If there's treatments with beta blockers or ACE inhibitors, this can impair our ability to effectively use medications when a systemic reaction comes up, but there are some other medications that we can use to help out if they are on some of these conditions. So it's not a hard contraindication, but it's certainly one where we exercise caution. Mast cell disorders, and then potentially if there is autoimmunity or if there's some malignancy going on, you want to have a good conversation with your other subspecialists. You want to make sure your patient is kind of completely understanding these things. Exercise a lot of caution if you have those specific scenarios where you're considering subcutaneous immunotherapy. The age, here we have less than 4 that's listed here. It's somewhat arbitrary. Again, largely what has been in clinical practice is at the age 4 and above is where subcutaneous immunotherapy will be initiated. However, this is something that there is potentially some, and that comes from our literature, essentially. Our literature has studied individuals who are young as, 5 years of age who have undergone immunotherapy, and then outcomes were looked at. And so that's where our data is limited. Are there practices that do immunotherapy younger than that? There certainly are. In terms of what we at our tertiary care center do, we largely practice doing immunotherapy on individuals who are 4 years of age and above. And you will kind of see that similarly when you are in your fellowships as well. Now, pregnancy is not a specific contraindication if the patient is already on, let's say, subcutaneous or sublingual immunotherapy. There is some caution that is recommended we exercise if you're considering starting somebody on immunotherapy. There are also not any strong recommendations from any organizations in terms of starting immunotherapies for somebody who is currently pregnant. And so that's where additionally we exercise some caution. So when you are looking at all of these things, there may be a sheet in clinic or something like that that you fill out where you're looking at indications for allergen immunotherapy. This is one such form that's in our clinic for individuals who have allergic rhinitis, conjunctivitis, asthma, atopic dermatitis, and then again a little bit beyond this talk, but Hymenoptera allergy as well. So there's a couple of terms here, and you've seen that I've kind of, they've been listed throughout some of the slides here. So allergy shot is kind of a colloquial term that's used. We are going to specifically use the term allergen immunotherapy. This is a term that is used for treatment that's modifying your allergic response to allergen exposure. This is also the correct terminology that we should be using for immunotherapy. And then in addition to that, other terms include specifying the type of immunotherapy. So I mentioned that earlier, subcutaneous immunotherapy and then sublingual oral immunotherapy. Oral immunotherapy, this may be referred to when we're talking about things that are beyond aeroallergen immunotherapy. So for instance, with potential food allergies, there are some FDA approved oral immunotherapies, but again, a little bit beyond the scope of this talk as we are focusing on aeroallergen immunotherapy here. So allergen extracts, we are going to have standardized extracts as well as non-standardized extracts that are available for allergen immunotherapy. Some such non-standardized extracts includes weight per volume and then protein nitrogen units. And then some such standardized extracts include allergy units here or bioequivalent allergy units. And then we, of course, take into consideration the concentration of the major allergens. And then your vials come labeled with your concentration as well as your dilutions. So if you have a 1-to-1, which is the highest concentration we can do, or if there's a dilution, largely these will be labeled accordingly on the actual vials you receive, and we're going to see in a subsequent slide here what those vials actually look like. So what types of allergen extracts are available for aeroallergen immunotherapy? These are some of the ones here. We have aqueous, which include glycerinated or ones using human serum albumin, HSA here. We have allergoid, polymerized T-cell peptides, or CpG related ones, so immunostimulatory sequences. And I should make a point here. Largely, we are currently utilizing aqueous extracts, but these other ones are still utilized for aeroallergen immunotherapy. So what about, let's say you have already taken all that into consideration and you're thinking about, and a patient qualifies for immunotherapy and they're receiving allergen immunotherapy, let's say in your office. What are different ways this has been practiced, and what is the preferred way of practicing this in your clinic, for instance? So we have one modality called off the table or board, where you have a single syringe, but you draw extracts from various vials, let's say, that are relevant to the patient. But ultimately, that single syringe is what is administered to the patient. Then you have shared single vials, where you have a single vial, but multiple injections can be given from that single vial. Then you have shared mixtures, where you have mixtures that are pre-prepared, and that same mixture can be given to multiple patients. And so the extract is drawn from that vial and then it's administered to the patient, but then that extract can be re-sterilized and administered to a different patient. That's a different modality that has been utilized. Patient-specific vials is when you have an extract that is prepared for a specific patient based on their history, their sensitization pattern, etc. And these are the vials that will follow the patient. You only are administering those vials to that patient. And also you are including, again, what they're sensitized to. So it's not some general extract that was obtained from the company that kind of just like arbitrarily includes what the patient is allergic to. So that's so patient-specific vials, again, include extracts that the patient is sensitized to, and they are only administered to that patient. This is currently the preferred modality of how we administer subcutaneous aeroallergen immunotherapy when we are administering it to patients. But like I said, these other types of modalities could be something that you see other, like say for instance, you're rotating in private practices or practices beyond where you're in fellowship, you could see that. Okay, so general rule of thumb, so this is emphasizing that specific point. We ideally prepare patient-specific vials. And so how do we increase the safety of that? We also want to label those vials with identifiers and then make sure those identifiers are verified every single time your patient comes in for aeroallergen immunotherapy. We're going to include some more information about that in some subsequent slides here. We include an effective dose for each component, although sometimes this can be a little challenging with some changes that are made with different companies that are providing extracts, but ideally we still aim to have an effective dose for each component. We avoid mixing incompatible extracts, so we are not mixing mold with aeroallergens, for instance, due to the proteolytic enzymes degrading the pollens from the mold. You're avoiding inclusion of cross-reactive antigens, again, to reduce redundancy, and then you're the way that they're mixed could be one of two ways. The manufacturer could mix the aeroallergen extracts and then deliver it to your practice, or your practice could actually mix the extracts as well. Both are kind of ways that is practiced in the United States. A note about USP 797. This is a set of enforceable sterile compound standards for safety measures that have been implemented in the United States, and it applies to compounding pharmacies and facilities involved in preparing those compounded sterile preparations. So there's a lot of requirements for this. For the sake of time in this talk, we're not going to go through all of them, but do know that any practice that is performing compounding of extracts do have to follow these USP 797 guidelines. Okay, how about determining how much dose to put in an extract? How do we do that? The first thing we have to know is what is the potency of current extracts available from manufacturers. So you can see some of the ones that are standardized as well as non-standardized listed here. For instance, cat hair and pelt would be 5,000 to 10,000 BAU per ml. We see the dust mite concentrations, Bermuda grass concentration, ragweed concentrations written here, and then also make a note where the units are a little bit different here. And then we have other pollens that are non-standardized, and then molds that are not standardized as well. So all of those things we do want to look at and take into consideration when ultimately you are determining the dose that goes into your patient's extract. This is another table that emphasizes that point, and it also really delineates what is standardized and not standardized. So dust mite, cat, grass, particularly certain types of grasses, are standardized, including, and then ragweed as well. So these are standardized extracts, and then non-standardized extracts include dog, other types of pollens, molds. Those are non-standardized extracts that are available for aeroallergen immunotherapy. So we talked about the potency and how that differs, and then the probable effective dose range is kind of determined based off of that. And so we use that to apply what we're actually putting into the patient's immunotherapy injections. So in our practice at our tertiary care center, we are utilizing 5 ml vials. The reason being is because we largely practice with pediatric patients here. If you are practicing with adult patients, you could be utilizing 5 ml vials, or you could be utilizing up to 10 ml vials. So know that this is just a sample representation of what you could be doing in your specific fellowship or in your specific practice. Other things that determine this also are based on kind of the concentration of the extract, you know, whether like in terms of their concentration related to like their aqueous solution or things like that. So those things we all take into consideration when we determine ultimately this part here, the dose that goes into the extract. Ultimately, we are aiming to have a dose that is effective for your patient long-term, a dose that is going to be something that is tolerable to the patient. Certain extracts listed here, for instance, cat as an example, could be more irritating to the patient, so you want to have something that is tolerable to the patient, and a dose that is indicated based on everything that we've discussed here. All of those things we want to take into consideration. What do allergen immunotherapy, subcutaneous immunotherapy vials look like? So they actually look like this. We have the 4 standard ones here, but I'm going to talk about one additional one on this chart down here. So these are going to be called green, blue, yellow, and red. And essentially these colors delineate what the level of dilution is with regards, and what your volume is essentially with regards to the actual dose. So the highest that you can have is your red vial. This is a 1-to-1 mixture, and this is ultimately what you are aiming to get to when your patient is receiving subcutaneous allergen immunotherapy. The rest of these are actually dilutions that come from your 1-to-1 vial. So your yellow vial is a 1-to-10 or a 10-fold dilution. Your blue is a 100-fold or 1-to-100. And then your green is 1-to-1000 or 1,000-fold dilution. A note about silver vials. So when you're using a standard manufacturer, they may not give you a silver vial. Like these 4 vials are going to, pretty much come when you order these from a manufacturer, for instance. The silver vial, essentially, it is utilized in specific scenarios for patients. If you have a patient, let's say, who has a prior history of undergoing aeroallergen immunotherapy, they stopped for couple of reasons. Maybe they had a reaction that was on immunotherapy. Maybe they had a reaction that was early on immunotherapy. If those conditions are present and now they come back to your clinic and they are wanting to reinitiate aeroallergen immunotherapy, and you know that they had a reaction, let's say, early on in your buildup phase, consideration of silver vial is relevant there. There are also some accelerated protocols for administration of immunotherapy where a silver vial might be relevant as well. So that is the nomenclature for labeling dilutions for these different vials for immunotherapy. It's also recommended that what's on the label, so you'll have the patient identifiers that are on the label, but also writing the expiration date on the label as well. So these are some standard times that will expire with regards to your extracts once they are mixed, but you want to make sure that that's labeled on your actual vial so you know how long it's good for, essentially. So the treatment schedule, and this is now we are talking more specifically about subcutaneous immunotherapy. There are some, this is talking about subcutaneous immunotherapy in terms of your like FDA, approved immunotherapies in the United States. Again, the non-FDA approved immunotherapies, particularly sublingual, if you are reading through various studies, you may see a buildup in maintenance phase. However, with regards to the FDA-approved tablets, there is not going to be a buildup or maintenance phase. So in this context, I'm largely, again, talking about subcutaneous allergen immunotherapy. So there's going to be 2 phases of administration in your treatment. The first is going to be buildup. So the buildup, largely, we think about essentially anything from either silver or green vial up through your red vial prior to your maintenance dose. It's where we are building up the dose of the aeroallergen immunotherapy. It involves receiving injections with increased amounts of allergen 1 to 2 times per week, up to 3 times a week. And that's for, again, this is, and I should put one more disclaimer here. Here we are talking about conventional buildup of aeroallergen immunotherapy. And these terms will kind of become important because you'll see the difference with different ways you can do buildup, essentially. The length of this phase depends on how often injections are received, can vary anywhere between 3 to 6 months, especially if your patient is coming in multiple times a week. Then, when you get to your highest dose of immunotherapy, you are now transitioned to the maintenance phase. And then with the maintenance phase, the effective dose, again, it depends on allergens, sensitivity in response to the buildup phase, but you can space out your allergen immunotherapy injections or subcutaneous immunotherapy at this point. And so how do we do that? What is standardized? The answer is that it's not. Every individual may practice a little bit differently with regards to frequency of maintenance phase immunotherapy injections. You will see some of us spacing out to 4 weeks. You will see some of us spacing out to 2 weeks. So that can be different depending on how the allergist practices. There may be a decrease of symptoms that occurs in the buildup phase, and it may take as long as 12 months on the maintenance dose to notice any improvement. And if allergy immunotherapy is successful, your maintenance treatment can continue for 3 to 5 years. There are some accelerated schedules that I'm now going to get into, which include cluster, rush, and ultra rush. And this is a pictorial graph that shows the schedule of AeroAllergen immunotherapy. All right, so types of accelerated schedules. So largely what I just talked about with buildup was conventional. There are accelerated schedules that refer to the frequency of injections that are received in your build-up phase. Again, this does not talk about anything related to the maintenance phase. In fact, what it's doing is talking about how fast you can get to maintenance phase. And so there's a couple of other protocols that are available here. We have cluster that's available, rush, and then ultra rush. What do all of these terms mean, and then how are the allergens dosed? Let's take a look at that a little further. So cluster immunotherapy largely is where we are receiving just that, clusters of different of the immunotherapy vials over a shortened time period that help get to maintenance faster. With this particular schedule, you do receive multiple doses of the injections in different visits here. We can see that this one outlines an 8-visit schedule. And with doing that, in one visit, for instance, you may receive more than one vial. However, you do not go up higher than, let's say, one vial beyond what you started with when you're doing cluster. So what do I mean by that? Let's look at this a little further. For instance, in visit number 1 with cluster, you have green and blue that you receive at a couple doses here. Here we are skipping numerous doses that are available in the build-up phase of a conventional schedule. In visit 2 here, we have blue and yellow. In visit 3, just yellow. In visit 4, just yellow, and then red beyond that. Why are there so many that are in the red? It's because your potential time of systemic reaction is going to be highest in this phase. So this is where we kind of go the slowest per se. Yeah, so this is kind of, like I said, spread out over 8 visits. What's the difference between that and rush immunotherapy? So rush immunotherapy is where you are delivering multiple extract dilutions in a single clinic visit. And there's a couple of different ways this can be done. You can do this starting at either green or silver and then go all the way up to red vial maintenance. That is one way you do rush. Another way, and a popular protocol, is one that I've listed here that I utilize in my own practice as well, where essentially we start at the silver vial and then we get about halfway through the yellow vial. The reason that I personally utilize this is this was studied in over 800 patients who received multiple who received AeroAllergen immunotherapy in this way, and the safety data was very, very favorable, 2% or less of systemic reactions for individuals who received it this way. So a note here that after you go through this protocol, you still have some buildup that's remaining to complete your rush immunotherapy. So again, other ways that rush can be practiced is where you build up all the way up to maintenance dose. And then, one more point I want to make about that. The difference between rush and ultra rush is how many doses you're administering of the AeroAllergen immunotherapy and how many doses are being skipped. Ultra rush is the most accelerated form of AeroAllergen immunotherapy. Generally, when providers are doing this, the patient could be hospitalized. They could have an IV started, and that is the one that is going to have the rate of systemic reactions is going to be much higher. And again, that generally is true for any of your accelerated schedules compared to your conventional schedules. And so there may be various preparation differences that you do. For instance, maybe some pre-treatment prior to undergoing any accelerated schedule. Maybe you obtain spirometry or peak flow prior to performing the immunotherapy the day of those procedures. All of those things are things we kind of take into consideration or implement in terms of safety measures before we do those accelerated protocols. But this is for your knowledge. This is a general point I want to make, is that these different dosing schedules for conventional are available, for build-up that are available that include conventional, cluster, rush, and ultra rush. When you're administering AeroAllergen immunotherapy. One important part about aeroallergen immunotherapy is making sure that informed consent is obtained prior to administering any allergen immunotherapy, which includes talking about treatment, alternatives to treatments, risks, benefits, costs associated with treatment, anticipated durations, any specific clinic policies or any specific office policies that affect treatment. All of that are things that the patient should have informed consent on prior to initiation. All right, let's say you have obtained informed consent, the patient has started immunotherapy, they're coming in for injections. What do we do prior to each injection being administered? And who does this kind of depends on the practice. But there are some pre-injection assessments that are important to perform prior to actually administering that shot. Firstly, and most importantly, are you performing this on the correct patient? So again, you want to make sure that those verifiers are validated with the patient. You check the name and date of birth between the vial as well as the patient and make sure everything is verified. Do they have a history of asthma, and have they had an increase in their asthma symptoms or use of reliever inhaler recently? Have they had a change in any of their allergy symptoms as well recently? How about any illnesses? Have they had any illnesses within the last week? Were there any issues that occurred within 12 hours of the last injection? Again, for most clinics administering aeroallergen immunotherapy, like subcutaneous, you're going to have a 1-hour observation that occurs after. But then after that, you could still have some delayed reactions that happen. So inquiring about those. Are there any medications that would change the way that a systemic reaction is treated? So largely here, we're talking about beta blockers, ACE inhibitors, any new ones that have been initiated since the last time you saw them. How about any new medical diagnoses since the last visit and any possibility of being currently pregnant? All of those things are things we want to assess prior to administration of the aeroallergen immunotherapy. So how do we inject subcutaneous? We're going to pinch the skin in the upper arm and then insert the needle. Upper arm is currently the most common location that is utilized for administration of subcutaneous immunotherapy. You can pull back and check for blood. If there is blood, you remove the needle and try again. You obviously don't want to inject intravenously. And then you inject subcutaneously, remove the needle, and apply pressure for about 30 seconds. If they have a little bit of bleeding, of course, you can put some Band-Aid over it. After the injection is administered, we want the patient to wait 30 minutes. After that time period, I think I said 1 hour earlier, but I meant to say 30 minutes. Most systemic reactions occur in that time frame, and then they should be checked prior to leaving for any new symptoms that they're having, and then check the site for any issues that they could be having. Again, it is possible to react after 30 minutes of the injection being administered. So for those reasons, a couple of things we take into consideration. Firstly, are you prescribing epinephrine autoinjectors for your patient? There are different schools of thoughts on this. So, in terms of the conventional immunotherapy buildup and then maintenance, I kind of told you the risk of or I might not have said that actually earlier. So the risk of systemic reactions here is going to be about 1% or less. So it's low, but it's not zero. And so some practitioners or providers or physicians take that into consideration and prescribe all individuals who are on subcutaneous immunotherapy with an epinephrine autoinjector. However, this is not a hard recommendation according to any guidelines that we have on doing so, and so some providers may not. And so I think the most important takeaway from that is whether you are or not, having some instructions that are given to a patient on what to do if a reaction does occur once you leave the clinic visit. That's going to be prudent for your patients who are on subcutaneous immunotherapy. Local reactions are possible and common. They can include erythema, swelling, heat, pain at the injection site, and right now, we don't see very clear evidence that local reactions do predict systemic reactions in the future. So we largely just treat the local reactions. We try and prevent them if possible. You can apply ice, hydrocortisone, stronger topical steroids if needed. You can pre-medicate the patient. You can decrease the dose of buildup for patient comfort. If you have a single vial, you can consider splitting it into 2 smaller injections. Also, another thing, of course, is I kind of talked about earlier, consideration of the dose that's put into the immunotherapy. That's another thing you kind of think about. Now, of course, if you're doing this last measure here, you're going to have more injections that are administered to the patient. So something else to take into consideration. The facility that is administering the immunotherapy should be prepared to treat any and all allergic reactions, including systemic reactions and severe systemic reactions. What are some symptoms of a systemic reaction? This can include urticaria, angioedema beyond the site of injection, increased respiratory symptoms, feel of pending doom, whole body pruritus, gastrointestinal symptoms, uterine cramping, hypotension. The symptoms are pretty rapid when they come on. Again, delayed reactions have been reported. And then again, there's a very low incidence of this. I think I quoted about 1%, and here we have quoted between less than 0.05% to 3.5% of injections in 1 in 12 in patients. So they're rare, but making sure your facility is very prepared in terms of treating these if they are to occur, and making sure your patient is fully educated on what can occur as well. What are some factors that can increase the risk of a systemic reaction? Here are some. Symptomatic asthma, a high degree of allergen hypersensitivity, use of beta blockers or ACE inhibitors, dosing errors. And again, this kind of impairs how a systemic reaction is treated as well. Dosing error, a prior history of systemic reactions, injection from a new vial. In order to kind of get around this right here, sometimes you drop the volume you administer from the new vial, and then injection given during a period of high symptoms for the actual patient. As you know, for anaphylaxis, epinephrine is the treatment of choice. Aqueous epinephrine 1 to 1,000 is the standard of care. This is preferably administered intramuscularly in the lateral thigh. For adults, we can have 0.2 to 0.5 administered every 5 to 15 minutes up to 3 times. And then for children, it can be 0.01 mLs per kg for body weight. Again, the same. And then in terms of your auto-injectors, those are going to be available in 0.1, 0.15, or 0.3. So that's dosed according to the patient's weight. If you have the beginnings of a systemic reaction, one other thing that can be done is placing a tourniquet above where the injection was administered. So it's imperative that you have good trained staff that know exactly where to administer that, and they leave room for such a tourniquet to be applied if a reaction were to occur. And essentially what this helps is reduction of allergen absorption or antigen absorption from where it was administered to systemic. And so applying a tourniquet pretty tight there, laying the patient down, all of those things can kind of assist when you're having a systemic reaction occur. Other medications can be considered, including H1 antihistamines, including first generation H1 or second generation H1. Currently, in terms of what we have recommended, there is a preference to use second generation H1. This is more effective with less side effects. H2 antihistamines, there's not a strong role here for utilization of these. There used to be a thought that corticosteroids could reduce late phase reactions. Currently, that's no longer recommended. Oxygen and bronchodilators can be helpful and should be administered depending on if there's hypoxia or if there's respiratory involvement. If you have pending or if you have present vascular collapse, then administration of IV fluids. And then again, tourniquet, that point is emphasized here again. How about dose adjustments? Over time, after getting 2 to 3 injections from maintenance, you can spread out. Again, I think most practices spread out every 2 to 4 weeks. Some individuals can even tolerate spreading out to every 6 weeks, but you want to make sure you've consulted with the allergist first. And then injections from new vials, like I mentioned, to reduce the risk of a systemic reaction, we do first dose reduced. If we tolerate that, then we resume full dose. Following a systemic reaction. So here we just have a general recommendation on how to reduce here. However, there's a lot of different literature that recommends how to reduce a dose after a systemic reaction. So you want to make sure you're kind of discussing that with your clinic in terms of what your clinic practices and becoming familiar with that, especially for those clinic calls or calls that you may receive and, they ask you, well, what do you want to do next after this has happened with an injection? Missed immunotherapy injections are common. Life happens for patients, and so there's various schedules on what to do if you've missed immunotherapy injections. And this can differ based on a couple of different factors here. It differs if you're in the buildup phase or maintenance phase, firstly. And then it also differs based on how many, it could differ based on how many weeks or how many actual days from the last time you received an injection. Again, this is just a general thing that's outlined here, but your clinic may practice something differently. Just make sure you get familiar with your hospital or clinic's schedule on what to do for that. How about the effectiveness of aeroallergen immunotherapy? So there have been a lot of studies here that have been published on this, both with standardized extracts as well as multi-allergen extracts that may include non-standardized extracts. There was one such study here with 51 clinical double-blind placebo-controlled trials that evaluated symptom scores and medication use, and that demonstrated statistical significance with regards to reduction in symptom score as well as medication use, which was a medication score. So the bottom line here is that aeroallergen immunotherapy has been shown to be effective reproducibly in studies for both reducing symptoms as well as medication use. How about improvement in asthma symptoms? So, that's with the presumption of rhinitis symptoms. So how about with the improvement of asthma symptoms after you've received subcutaneous immunotherapy? So a couple of things that have been looked at here include the actual allergen that was administered for the patient. So here we have in one study from American Journal of Respiratory Critical Care Medicine listed here for dust mites as well as other. And then all studies combined here was listed at the bottom. And so odds ratios and 95% confidence interval here are looked at for these specific patients. The bottom line here is that for dust mites, we see in various studies here a reproducible improvement or a reproducibly high odds ratio with regards to improvement in asthma symptoms after subcutaneous immunotherapy. And we see that same thing reproduced with other allergens as well. And then we see that same effect whether you look at mites individually, other allergens combined from these studies, or all studies combined together. This was a study that looked at a couple of different things here. A change in your symptom scores in individuals who are on placebo compared to those who are on immunotherapy, and then the development of asthma a certain amount of years after starting immunotherapy. You can see consistently here in terms of change in symptom scores, you had a lower symptom score here in those who were on immunotherapy, and in the placebo group you actually saw an increase in your symptom score, and you can see that these findings were statistically significant. How about the development of asthma symptoms? Here we have rhinitis patients developing asthma symptoms. That's how it's written here for individuals who are on immunotherapy. And we can see a significant difference here in the individuals who were on placebo who developed asthma symptoms compared to those who were on immunotherapy and then developed asthma symptoms. So that is, again, a reproducible effect that we have seen in studies. what is the total duration of subcutaneous immunotherapy? What is the data behind that? We know that with subcutaneous immunotherapy, for individuals who prematurely stop the immunotherapy, they can develop relapse of their symptoms. But individuals who complete a minimum of 3 years of immunotherapy are likely to receive long-term benefit. There's not strong evidence of benefit beyond that. However, studies have looked at up to 5 years and seen that same benefit, that there is benefit of doing between a 3 to 5 year range. And that is why some providers may practice doing up to 5 years, and some may, do up to at least 3 years and then give patients the option of, well, do you want to continue for another year to see if you get even any more benefit in symptoms? That's where kind of some of the art of this comes in. And then this is kind of demonstrating here that in terms of long-term benefit of symptoms beyond the time period where you receive immunotherapy, you do have a long-term benefit of your symptoms that you receive compared to those, and this study looked at individuals who were on placebo versus individuals who received the immunotherapy and whether they had benefits after that therapy was completed. And so again, another reproducible thing we see is that they have long-term benefits with their symptoms. A note on sublingual allergen immunotherapy. There are some FDA-approved sublingual tablets, as I've been referring to, including Timothy grass, which is approved at 5 years of age and above, a 5-grass pollen tablet. This one is with the northern grasses, a ragweed tablet, which is approved at 5 years of age and above, and a house dust mite tablet, which is approved at 12 years of age and above. Again, this data is for this moment in 2024. This could change. We could have the addition of other, sublingual tablets or changes in the age of initiation for some of these tablets as well. So we'll just kind of keep an eye on that going forward. All right, summary of allergen immunotherapy. AIT can reduce the sensitivity of an allergic patient to their allergen and lead to potential quote-unquote remission or long-term benefit of symptoms. Indication for immunotherapy includes the sensitization or presence of specific IgE, exposure to that allergen, evidence of symptoms after exposure, and informed desire by the patient to get immunotherapy. Medical conditions shown to improve with AIT include allergic rhinoconjunctivitis, allergic-induced asthma, atopic dermatitis. This is for, aeroallergen immunotherapy. And then Hymenoptera allergy is beyond this talk. There are certain contraindications for immunotherapy in two senses. One, in terms of baseline conditions, and two, conditions that reduce the likelihood of surviving anaphylaxis or the effectiveness of treatment of anaphylaxis. We want to use patient-specific vials. That's kind of our standard of how we administer subcutaneous allergen immunotherapy. Effective dose should be delivered, and then vials need to be properly labeled. AIT needs to be given safely, so we ask those pre-injection questions, have proper technique with injection, and observe for at least 30 minutes. And our total duration should be 3 to 5 years, or let me rephrase that. Our total duration can be and is usually effective at 3 to 5 years.